Okay. All right, so it's a tough act to follow Karen here, but I'm going to talk about HDACs, and I'm going to go over a little briefly because Anna did a great job of the epigenetic review this morning. Um, but one thing you have to know about HDACs is you start off with they're ubiquitous. They're in almost every organ, and they're not unique to cancer. I mean, there are abnormalities, neurologic disease, cancers, and almost every other disease. We typically talk about decetylase inhibitors and think about histones, but you have to also remember they have non-histone targets too, like transcription factors, chaperones, structural proteins, or DNA methylations. And they have a lot of downstream effects if you actually hit the HDAC inhibitor, HDAC, including the effects on cell cycle, apoptosis, differentiation, angiogenesis, and cell motility. Again, just a cartoon showing how HDAC inhibitors work. You know, we have a histone acetylase transferases, which actually acetylate the histones, and you unravel the histones and open up the DNA. The histone deacetylase is actually acetylated, and it closes up the histones around the chromosome there. And again, is that stimulates different downstream effects. Again, is that if you look at studies, HDAC inhibitors, if you inhibit enzymes, you can induce certain downstream genes, including P21, TPB2, gastrin, histone H2B, and cyclin E. There's others that are repressed that are listed on that side too. Again, the non-histone proteins that are known to be direct substrates for histone deacetylase enzymes are listed here. Important prostate cancer are the tubulins, beta-catenin, P53, ET2F, HDAC 90, protein 90, and RB, and c-MYC. Again, it's that HDAC enzymes, there's actually 4 classes. Class 1 is the most common. It includes HDAC 1, 2, 3, and 8. They're associated with HDAC 1 and 2 associated with pressive complexes. And HDAC 1 is actually associated with non-histone targets, particularly the androgen receptor. Again, class 2 is divided in 2, A and B. Again, is that has different effects there. The main one is that is of a great interest is HDAC 6, which is associated with the cytoskeleton proteins, including alpha tubulins. Class 4 only has one HDAC, HDAC 11. Again, it's not too much is known about that. And class 3 is the a lone class. It is NAD dependent. It's the sirtuins. Again, is that these are ubiquitous, but there's ongoing data that is actually becoming interesting in prostate with the sirtuins also. But alteration in histone acetylations, I mean, histone deacetylases are overexpressed in certain human cancers. They're recruited by oncogenic transcription factors, and histone acetylate transferases translocated to mutated in cancer. Again, this is just, there's a lot of data out there about the expression of HDACs in prostate cancer. This is an updated from the German group that actually looked over TMA over 8,000 prostate cancer specimens. And what they did find is a direct correlation between the expression of HDAC1 and grade of the cancer. But there is also association with the ERK protein itself. They also further correlated to the biochemical recurrence in these patients, and they also noted those with a higher expression of HDAC1 had a higher recurrence of the cancer itself. So HDAC inhibitors, there's 4 classes here, the hydroxamics, benzamides, cyclotetrapides, and the short chain fatty acids. Again, is the short chain fatty acids were the first ones used, which includes valproic acid and butyrates. Again, is that they probably are the weakest of the all the classes there, and usually it's these hydroxyamides such as vorinostat and belinostat have been mostly tested. Had the opportunity to develop a lot of these. Again, this is the program that we had at Memorial, where we actually look at SAHA. Again, this is a competitive or inhibitor of the site there. As you can see, it actually fits nicely into the zinc binding site there to block the HDAC enzyme. Very early studies in prostate cancer in CWR22, human prostate. Again, is that in a dose-dependent manner, is that tumor shrank when you actually gave it SAHA. Again, as it was well tolerated in these animals. And what was also very interesting, a biomarker actually developed from that, and looking at histone acetylation within the tumor itself. And this was very valuable as we took this forward into clinical trials. Again, it's that we first developed an IV formulation, then an oral formulation. Again, is that on the left-hand side here, you actually see the peripheral mononuclear cells we've actually isolated after receiving SAHA itself. And what we did see is that reproducibly, even at the lowest levels, we saw acetylation of H3 in the blood. Pre and post, and it kept there for around 2 hours after the infusion. And again, it's that repeated even out to 6 months out, we could see this still occurring. Again, it's that we did have the opportunity to get pre and post biopsies, and we did see at the higher dose levels, we saw acetylation in the tissue, and this was a prostate biopsy of a patient, and we did see increased acetylation in the tissue itself. With the oral, we actually further went on to develop an ELISA assay, which could quantitate some of the acetylation in the blood. And again, it's that we did show dose responses as we increased the doses of SAHA with acetylation. Again, it's that we did see some remarkable results very early with these drugs. This is a 17-year-old who actually had Hodgkin's disease, who actually relapsed twice from 2 transplants. And in a matter of 6 weeks, she had a dramatic response and symptomatic improvement, which was impressive. Again, we've actually had complete responses in this transformed lymphoma, who was disease-free over 6 months. This patient was also status post multiple transplants. Again, and this is the data from the oral study. Again, we saw a wide range of some activity, mostly in the hematologic malignancies, but we did see some activity in mesothelioma, some thyroid cancer, but basically it was mostly in the hematologic malignancies. Again, dramatic. Again, is that in cutaneous T-cell lymphoma. This is a gentleman with a very advanced after progressing on prior therapy, and again, a matter of 8 weeks, this is dramatic response in patients treated with SAHA. So when you see these type of patients, you say, well, that does work, Walter. Okay, shrinks tumor. All right. All right. Again, it's that the pivotal trial was by Dr. Duvak, who actually did this phase 2B trial. And they showed that around a third of the patients actually had symptomatic and also regression of disease. Again, low threshold to be approved, but for this disease, that was enough. The main side effects of HDACs are actually fatigue, which is actually dose limiting in most studies. And again, it's very variable per patient to patient. Some patients you can give HDACs and there's no problem. The other patient can't take 1 dose. So it's very heterogeneous across patients. Again, HDACs and T-cell development are listed here. Again, as depsipeptide has been approved, beninostat, as we talked about, has also been approved, along with belinostat's on approval route too. But what about solid tumors? That's been a whole different story. I mean, we've tried all these HDACs in multiple solid tumors, and it's actually dismal results. And, again, it's that this is just some data in prostate cancer, because it was very encouraging that, we had all this data showing histone acetylase decreases AR activity in hormone sensitive and refractory prostate cancer. HDAC inhibitor decreases endogenous AR levels. and affects transcription. So it's really, we thought that this would have activity in prostate cancer. However, this is a study from Dana Ravkoff, who actually looked at beninostat in there. Again, swimmer plot on the left. You can't get much more negative than that. Everybody progressed there, and no one had a PSA decline. Again, they said, well, let's combine it with something, like we always do as a good medical oncologist. They looked at beninostat alone, then also with docetaxel. Again, the combination showed no difference in the metabolism of docetaxel. Again, it's that beninostat itself really showed no activity. In the patients who got the combination, there was some activity there. 63% had a greater than 50% decline in PSA, including one patient who had previously progressed on docetaxel. So whether or not it does have activity or not is questionable. The last one was this phase 2 trial with a new HDAC inhibitor, SB939, patient with castrate-resistant prostate cancer, which is actually a very interesting study. If you look on the left, the best PSA response in waterfall plot there, again, is that you had, mild, I'd say mild effect on the PSA. But what was very interesting, when they looked at changes in CTCs and the proportion that actually had non-detectable CTCs, the majority actually did. So interesting. But at the end of the day, all the tumors progressed, and the conclusion was no clinical activity. However, really, that may not be all the truth. Again, as we go back and look at all the data from the preclinical data, we have to remember is that HDACs are very finicky. And this is a study actually showing if you actually look at belinostat and PC3 cells, depending on the dose and duration, the outcome of your will change. So if you actually give 1 micromolar of belinostat for 48 hours, you have reversible growth. Exposure at 4 micromolars of belinostat showed irreversible growth and inhibition. So it's very important that you have a significant concentration of your HDAC there, and it also is time dependent. So what I would actually suggest here is that you're looking at different compartments in prostate cancer. Again, is that you probably got suboptimal concentrations in the tumor itself, and that's why you actually got no PSA response. And there's actually data from multiple groups that you may actually cause some increased progression of tumors, while in the periphery, you actually had more concentrations or more optimal concentrations in the peripheral compartment, causing the changes in CTCs. So that really highlights some of the limitations of the HDACs. We know HDACs are ubiquitous. There's limited knowledge of these enzymes. Biologic functions of intravitreal HDACs is very different. As we look at the ones that are approved right now, there are subtleties between them. Regulation mechanisms of intravitreal HDACs are not really known, and role of intravitreal HDACs in cancer still needs to be investigated further. Again, it's that right now we have a variety of substrates, histone and non-histones, and they're all competitive right now, and we need more non-competitive drugs. And they're non-selective, evaluated in an empirical approach right now, unpredictable side effects, and mostly we have inadequate drug concentration exposure to tumor. Well, taking these considerations, when I was at Yale, I actually had the fortune to work with Mark Saltzman up there in this nanotechnology. And he did a lot of work looking at the glial wafers and responsible for that. So we hooked up there, and we actually developed a nanoparticle for urothelial penetration delivery of histones. And the whole idea is that we needed to get the drug to the right place in the right concentration for the duration in order to get an effect. Again, it's that we did get this molecule, and the data actually suggested that we get increased cell kill with these type of delivery systems. Again, this may be optimized if you actually give it to superficial urothelial cancer, where you can actually give it intravesically, which can increase the concentrations of these agents. So what can we conclude? HDACs are pan-competitive inhibitors. Similar toxicity profiles, clinical spectrum activity. There's activity in lymphomas right now. There's a modest activity in most solid tumors. Unfortunately, I don't think we have adequate tissue concentrations in solid tumors, which has limited its ability. Combinations of preclinical studies suggest increased clinical activity. And overall, we need to develop better strategies to optimize HDAC inhibitors. And just to carry on a little bit, and there's a lot of things that you can combine HDACs with, and this is just a partial list. And I think it's very interesting is that, this ties on to Karen's last talk, is that there's increasing data that if we actually combine these drugs in right combinations, we may have an effect. This is a really nice study from Olivia et al. That actually looked at olaraprib and Sawhall and showed significant cell kill when you actually use the combinations. But again, the question is, can we get the right concentration of HDACs with your olaraprib to get this effect? All right, and I'll stop there and take any questions.
So Kevin, I have a question and other people could answer as well. So you focused a lot about the effect of HDAC inhibition on the tumor. What is known about HDAC inhibition in the immune system, and could that possibly be a way to prime an immune system that could be followed up with a vaccine or a checkpoint blockade?
Yeah, I mean, there's been work looking at that as an immune modulator. So, we haven't done any of that work, but there are some other people that have looked at that.
It's really fascinating. I mean, large numbers of people have used molecular ways to interrogate the individual HDACs. And what's really clear is that you don't want a pan HDAC inhibitor because some of them are helpful and some of them are harmful. They're basically cell context dependent. So you have to tweak it. You have to figure out which ones you want. I've actually been working with HDAC4. And the reason is because prostate cells don't need it when they're happy, but they upregulate it when they're under stress. And if you block it, you have a tremendous ability to prevent them from undergoing, especially survival pathways. But it's been discovered by at least 5 different companies, big companies, and that have used chemistry to try to make small molecule inhibitors of it. And ironically, you would think that we'd eventually have more specific ones. The problem is the chemistry is fine, but then they take the molecule and they try to take it into animals. And this is a really good statement for the industry here, because they'll get a beautiful molecule that will work in a tissue culture dish. But when they go to give it to an animal, it has a 25-minute half-life in the blood, and it's bound up. So essentially, they've lost 5 years worth of work because they can't go any further. They got to go back and get a molecule that's deliverable and actually penetrate. So what's really interesting at these meetings is we'll hear about these molecules which have come up the in vitro scale. Anybody that's thinking of using them in animal studies or tissue cultures should really make sure that they want to not waste their time, but make sure that they know as much of these, whether these are going to be able to be useful in essentially outside of a biochemical assay. Because this area is a poster child for this. Yeah. We've got tons of really specific molecules for specific into HDACs, but they're not druggable. They're essentially targetable, but not and actionable, but not druggable. So in your situation, I mean, you must be frustrated because you've got signal, and you're now trying to tease out which ones you want to hit, which ones you don't want to hit. So what are you trying to do?
I've moved on. I just give an example. Is that we actually brought Saha into clinic. It was only dissolved in a pH of 11. All right, that's the technical difficulties you get with these, is because they're very specific, and and that was a huge hurdle to come over to even get into the clinic. So, thank you.